Good afternoon, everybody, and thank you so much for joining us this afternoon. Today's webinar is Behavioral Assessment and Intervention for Self-Injurious Behavior, and I have the honor of introducing Dr. David McAdam. Today's presentation is made available through a program called the Rochester Regional Center for Autism Spectrum Disorder, and we are one of many programs located in the Strong Center for Developmental Disabilities here at the University of Rochester. The Strong Center is considered a university center for excellence in developmental disabilities. That's part of the nationwide Association of University Centers on Disabilities. So there's plenty of resources on our website and opportunities to get involved, and I encourage you to check that out. To give you just a little background about the Regional Center for Autism, you'll see on this map that we are actually one of 7 across New York State. We are funded by State Ed, and our headquarters are in Albany. And you'll see those 12 blue counties are our catchment area for here in Rochester. And our main goal for all these regional centers are community education and technical assistance around autism and related disabilities. And one of those activities being our webinar series. So today we're joined by David, and I just wanted to let everybody know that our next webinar will be on Wednesday, March 14th with Caitlin Richardson, who's our Director of Employment and Policy here at Strong Center for Developmental Disabilities. She'll be discussing employment and a new resource for individuals living in New York State called My Path New York. So that'll be a really interesting, exciting webinar talking about a new resource, and I encourage everybody to check that out on our website and register for that as well. Before I pass it off to David, just to let everybody know that following today's webinar, I'll be sending out a link to a survey. We appreciate your feedback and how we can make these webinar presentations more informative. And we welcome your feedback and any questions. And if you are looking for a certificate of attendance, perhaps for CEUs and things like that, you have the opportunity to select that in the survey. Any questions, please feel free to use your chat box this afternoon, and then we have the ability to unmute you if you'd like, or just feel free to type in the chat box and David can respond to your questions from there. So without further ado, I'd like to introduce Dr. David McAdam.
I would like to welcome everyone to my webinar on self-injurious behaviors of individuals with autism. And just to give you a little overview of what we're doing today. So first of all, we're going to start off by talking about a little bit about challenging behaviors in general. We're going to move on to SIB, self-injurious behavior. We're then going to talk about some of the risks associated with self-injurious behavior. Essentially, why should we all be concerned if we meet someone with autism who engages in self-injurious behavior? We're then going to talk about the reasons why. So there's a series of documented reasons why individuals engage in self-injurious behavior. So there's medical, biological reasons, and there's also operant reasons. And operant reasons is individuals with autism learn to engage in self-injurious behavior because it produces some outcome from their perspective that's favorable. So it is a great way to recruit attention. If you don't have really good expressive language skills, self-injury can serve as a way to get you out of something you don't want to do, for example. So after we talk about the purposes of self-injury from the perspective of the individual with autism, we're going to talk about what are the ways to figure out why a particular individual engages in self-injurious behavior. This is a critical question because self-injurious behavior, as you'll see, about 60% of it is social. That is, the person's doing it to influence the way other people interact with them. And about 40% of it is maintained by what behavior analysts like myself refer to as automatic reinforcement. And automatic reinforcement is just our fancy behavioral word for the fact that there's something enjoyable or pleasurable the first person finds from engaging in SIB. Then we're going to talk about interventions for self-injurious behaviors. And at the very end, we're going to talk a little bit about what are those interventions that are realistic for parents and teachers to try on their own? And what are those interventions that may require support from someone like myself who has expertise and professional training and strategies to reduce self-injurious behavior? So starting off sort of broadly looking at challenging behaviors in general, what are challenging behaviors? They're essentially behaviors in which an individual displays at a frequency or intent at a high enough intensity that they jeopardize their placement in community-based settings, and they also limit their opportunities to interact and contact things in their communities, which is simply another way of saying that challenging behaviors are those behaviors that interfere with learning and decrease an individual's quality of life. So they tend to restrict your opportunity to go out and eat with your family in the community. You may not have the opportunity to go and shop at the mall because of the intensity or frequency of your challenging behaviors. What are the common types of challenging behaviors displayed by persons with autism spectrum disorders? Common challenging behaviors are SIB, our topic for today, aggression, stereotypic behaviors, tantrums. So a tantrum is typically non-compliance paired with some other form of challenging behavior. The other forms of challenging behaviors are typically things like negative vocalizations, screaming, aggression towards other people. Property destruction is another common type of challenging behavior displayed by individuals with autism. Feeding problems. So a great example of a feeding problem is many children, for example, with autism are very picky eaters. So kids in general tend to be picky eaters, but many children with autism, for example, will only eat 3 or 4 particular items, typically things that aren't healthy for them. So pizza, hot dogs, those sorts of things. And then at the bottom of the slide, there's 2 particular types of challenging, 2 particular forms of self-injurious behavior, pica. So pica is eating non-edible objects. We're going to talk about interventions for pica in a little bit more detail today towards the end of the webinar, because in the survey we sent out, a couple individuals responded that the form of self-injurious behavior they were most interested in was pica. The last comment type of challenging behavior is rumination. Rumination refers to bringing up the content of your stomach, moving them around your mouth. Happens fairly rarely with individuals with autism, but when it does happen, it's a pretty significant concern because rumination is associated with a whole host of medical complications. So esophageal erosion, for example. So now we're going to kind of focus in on self-injurious behaviors. So what is our definition of self-injurious behavior? Our first definition is provided by the Krieger Institute at the Johns Hopkins University School of Medicine. And in terms of behavioral interventions to reduce self-injury, the Krieger Institute has probably produced the most and best peer-reviewed data in the country, if not the world. So they are real experts on self-injury. So they define self-injury as the occurrence of a behavior that results in physical injury to one's own body, which is a very similar definition to the one used by the Center for Autism Research at the Children's Center in Philadelphia. So self-injurious behavior can take a variety of different forms. So the technical term for forms is topographies. So what do self-injurious behaviors, what might they look like? So banging your head against hard objects or surfaces is a relatively common form of self-injury. Pinching oneself, hitting oneself. So hitting yourself might consist of hitting your head with both, simultaneously with both hands in sort of an upward motion towards your head. Arm biting is a form of self-injury we see. Picking one's own skin or sores. Pica again, which is the ingestion of non-edible objects. Excessive skin rubbing or scratching and rumination. So what are the general characteristics of individuals with disabilities who display self-injurious behavior? So there's a little bit of evidence for a gender effect. Roughly 57% of individuals with self-injury are males, 43% are females. There's a strong correlation between developmental age, and the other term for developmental age is IQ, and self-injurious behaviors. So the more severe your developmental disability is, the more likely you are to display self-injury. The majority of individuals with disabilities who display self-injury have a level of intellectual functioning that in the severe or profound range of intellectual disability. There's other secondary conditions that are often associated with self-injury. These include individuals with visual impairments and a developmental disability are more likely to engage in self-injury. About 10% of individuals with autism, and about 6% of individuals with hearing impairment. So this slide again, really sorry, I think it repeats the earlier slide, but it shows you, again, the various topographies of self-injury. A couple pictures here. The upper one's a child biting their hand, and that's a fairly common topography or form of self-injury we see with individuals with developmental disability. And the bottom picture is an individual who has trichotillomania, so they pull out their own hair, which is another fairly common form of self-injury that we see. So the next question is, what are the documented negative consequences to an individual of engaging in self-injury? The big one is that self-injury interferes with learning. So individuals with autism and other developmental disabilities, in general, acquire new information at a little bit more modest rates than their peers without disabilities. And when you combine having a developmental disability with self-injurious behavior, research shows that those individuals even acquire new information at an even slower rate. So self-injury interferes with opportunities to learn new information. There's clearly an increased monetary cost to serve individuals with SIB in their lifetime. There's actually some pretty good data on this. So individuals with the most severe form of self-injury cost thousands of dollars more in their lifetime in terms of services that they require than individuals with the same level of a developmental disability, but who do not display severe self-injury. Self-injury oftentimes restricts an individual in terms of their living placement. So individuals with self-injury tend to reside in more restrictive residential settings. So for example, they may need to be supported in a community-based group home instead of living at home with their parents. Individuals with self-injury are a group of individuals who oftentimes are referred to specialists in the treatment of their behavior. So in the case of self-injury, that would typically either be someone like myself, PhD level, board certified, New York State licensed behavior analyst, or a licensed psychologist. And in the case of severe self-injury, hopefully those people have received training in how to work in the behavioral assessment and treatment of individuals with self-injurious behavior. So like myself, I did a postdoc fellowship at the Krieger Institute. One of the populations that my training focused on was individuals with severe self-injury. So if you spend time with an individual with autism that engages in self-injury, probably the big question you ask yourself is, why does the person do that? So why would anyone engage in a behavior that results in injury or tissue damage to themselves? And that's a question that's puzzled researchers for a number of years. Fortunately, we're at a point in time where we have an understanding of the causes of self-injury. The thing that's important to recognize about the causes are that they're directly tied to the individual having a very comprehensive behavioral function, which means that you can't simply go out and meet someone that has self-injury, spend a period of time with them, observing the behavior, and then identify the cause or purpose of their self-injury from the perspective of the individual. So what needs to happen is there needs to be a comprehensive assessment conducted. So what are the factors that cause self-injury? We know that there's a whole bunch of what we refer to as biological set-in events. So a biological set-in event is a global condition, when it's present for the individual, increases the likelihood that they'll engage in self-injurious behavior. So one of those factors that has been documented for people with disabilities is chronic ear infections. So Mark O'Reilly has a nice study in the Journal of Applied Behavior Analysis. And what Mark does is simply track a child with autism over the course of time. They had reoccurring chronic ear infections. And he shows that in periods of time in which they were being treated for an ear infection, their rate of self-injury was high. And times when they were free of ear infection, their rate of self-injury was low or at zero levels. So in this case, chronic ear infections are what we refer to as a biological set-in event. They're a medical condition that's directly linked and produces self-injury under particular circumstances. So, for example, I might be more likely to display self-injury when I have an ear infection when you ask me to do something that I don't particularly like to do. So when you place instructional demands on me, or you give me directives to do something I don't like to do. So I'm a young child, you ask me to brush my teeth, I don't like to brush my teeth. Other biological set-in events that have been documented to be associated with self-injury includes headaches, esophageal reflux, other GI issues. sleep deprivation. Ted Carr has a nice study with adults with disabilities where he shows that mood is related to challenging behavior such as aggression and self-injury. And allergies are also thought of as a biological set-in event. My eyes are watery, that results in me rubbing my face. I then create skin irritation, which I pick, which results in an injury to myself. People have also demonstrated that certain environmental conditions may produce self-injurious behaviors. These include noisy environments, crowded situations, and the presence of particular people or activities. And again, Mark O'Reilly demonstrated this in a study he published in the Journal of Applied Behavior Analysis. So it was with a young child with Williams syndrome. Individuals with Williams syndrome are described as being hypersensitive to noise. They compare a situation where there's loud music to a situation that's relatively quiet. And sure enough, the young man is much more likely to engage in self-injury in settings that are very noisy. So then the question really becomes, what does self-injurious behavior do related to these biological conditions that produce self-injury, that's associated with self-injury? Well, the theory is that self-injurious behavior oftentimes is a way for the person to mask or relieve pain associated with the particular medical condition. And essentially the theory here is so I have a headache and I hit myself in my head, what that does is alter my brain chemistry. And altering my brain chemistry is essentially is a biological way to relieve the sensation of pain. And this theory is fairly well supported in the research literature and a large number of fairly technical studies. If you're interested in those, my email address is at the end of the presentation. Send me an email. I'll be welcome to share some articles that go into the exact details and theory about how that occurs. There's also a variety of genetic conditions that are associated with self-injury. So individuals with these particular genetic conditions are much more likely to engage in self-injurious behavior. And these genetic syndromes are all single gene disorders that there's a clear genetic marker for. So there's a genetic test that determines whether or not you have them. So individuals with Prader-Willi, for example, are susceptible to uncontrollable eating and engagement in skin picking, a particular form of self-injurious behavior. So one category of causes for self-injury is the medical causes. And again, those are relatively well established in the published literature on self-injury, but there's also equally well established are operant causes. So by operant causes, we're talking about what operant causes refers to is the fact that a person has learned to engage in self-injurious behavior because their self-injurious behavior produces something that they find useful It controls the action of other people is another way to look at it. And you think about individuals with autism and other developmental disabilities, oftentimes they have, delays in both receptive and expressive language. And self-injury is a really good way to tell someone to give you something that you want or to tell someone to take something away. So what's our first behavioral cause of self-injurious behavior? That's what we refer to as social positive reinforcement. Some people also refer to it as positive reinforcement. And I think it helps, if this is a new concept to you, to think of this as the behavior gets the person something that they want. And what does the literature show? Well, there's two things that people want. So the one thing is self-injurious behavior for some individuals is a great way to get attention from other people. Self-injurious behavior is also a good way to gain access to things that you like, high preference items or activities. So if you're a young child, you have minimal communication skills, self-injury may be a great way to tell your parents, I'm hungry, I want some cookies. It may be a great way to say, I want my stuffed animal, I love stuffies. And if you're a parent and in the moment your child's engaged in self-injurious behavior, you're thinking to yourself very reasonably, what I want to do is I need to stop this behavior. You stop the behavior maybe by giving your child access to some item that they like, food, a preferred toy, and then pretty soon your child, because your child have minimal language skills, they're using their self-injurious behavior to communicate to you that they want a particular thing. So example of positive reinforcement, individual hits themselves in their head with their hand. Every time they do that, their parents say to them, stop it. They sort of encourage them not to engage in self-injurious behavior. And over time, what happens is self-injury becomes a great way to recruit attention from people around you. So from the perspective of the person, they've learned that their self-injury works for them. The other operant learned cause of self-injury is what we refer to as social negative reinforcement. Some people refer to this as negative reinforcement. You can also refer to it as escape or avoidance behavior. Again, if you're new to this concept, I would think of negative reinforcement as simply a behavior. It's a great way to get you out of something that you don't want to do. And what are those activities? Well, particularly with individuals with autism, we tend to see they may not like to do a particular type of academic work. Seems like it might be something like, I don't have great fine motor skills. I don't like to do math worksheets because they require me to write. I hit myself. It tends to either allow me to get out of the activity. I think activities of daily living are another great example of behaviors maintained by them where social negative reinforcement may come in. You ask me and you tell me to brush my teeth. You try to help me brush my teeth. I start biting my hand and hitting myself. Many people would have the tendency to stop asking the individual to brush their teeth because they don't want them to hurt themselves. And And what happens over time, the individual learns that self-injurious behavior is a great way to get their parents to stop asking them to brush their teeth. And sometimes the bottom bullet is, self-injury can serve to just avoid a situation entirely. So you're at home, you see your parents get out the toothbrush and the toothpaste. Even before they ask you to do anything, you start engaging in self-injury because it's going to delay or prevent your parents from asking you to brush your teeth. So that would be an example of avoidance behavior. So an example of negative reinforcement, using brushing your teeth as an example. But the key thing about these examples is, you project into the future. What happens if self-injury results in you getting out of brushing your teeth? Self-injury then, in the same or similar situations, is highly likely to happen in the future. Well, why is it highly likely to happen in the future? It's highly likely to happen because the behavior from the perspective of the individual with autism works for them. And if it works for them, why should they not continue to engage in it? In a behavioral model, there are situations in which an individual's self-injury is not maintained by social factors, so it's not influenced by how other people interact with them. And we refer to this as automatic reinforcement. And automatic reinforcement is more commonly referred to as sensory reinforcement. And it's the concept that the person engages in self-injury because there's something enjoyable or pleasurable that they find, that they get out of engaging in the behavior. And what they find enjoyable or pleasurable is not mediated or provided by other people. So the key of determining if a behavior is maintained by automatic reinforcement, the key question is, will the person continue to engage in the behavior when no other people are with them? So if they're in the front room of their house by themselves watching TV, will they continue to engage in self-injury? If they were sitting in their room alone and other people weren't interacting with them, would they continue to engage in self-injury? If the self-injury is automatically or sensory maintained, because what the person is getting out of the behavior is internal and not influenced by other people, in situations where they're alone, they should continue to engage in self-injury. And you're going to find out later in the presentation, we really need to know whether or not self-injury is socially maintained or non-socially or automatically maintained, because you do dramatically different things in terms of interventions for socially maintained self-injurious behavior compared to automatically maintained self-injurious behavior. So that's a critical distinction for you to make if you're going to help someone reduce their rate of self-injury. So example of automatically maintained self-injury, again, person is alone, no one's around, they continue to engage in the behavior. Another way to look at this is if, I go into my front room of my house to watch TV and no one's around, am I equally likely to engage in self-injury when I first sit down, the first 2, 3, 4, 5 minutes I'm watching TV, as I am at the very end of the activity? So if my self-injury is automatically maintained throughout the activity, I should engage in self-injury. If it's socially maintained, I might do it a couple times at the start, but there's no one around to reinforce it, to respond to it. I can't control the actions of other people. So my self-injury should stop relatively early on in the activity in which I'm alone. To make self-injury even more complicated, just wanted to briefly mention there is, and has been since the late 1950s, an arousal theory of self-injury. And this is the concept that kind of can work in two directions. So one direction is I'm under-aroused in from a physiological perspective. And what my self-injury does is increase my level of arousal to its appropriate level. So it helps me sort of acquire a balance from a physiological perspective. And then arousal theory can also work the other way. I'm over-aroused, and self-injurious behavior is a way to relieve or reduce my over-arousal. From an arousal theory perspective, the way we would most often treat self-injurious behavior is through medications that reduce or affect our blood pressure and our heart rate. As I note here, arousal theories are as popular today as they were in the 1950s. They have been proven to be very difficult to confirm from a scientific research perspective. So whether or not there's a strong link between hyper or hypoarousal and self-injury is yet to be firmly established. From a behavioral perspective, when we're talking about self-injury, particularly self-injury so we're focusing here on self-injury, it's socially influenced. So we're talking about the social positive reinforcement, the attention to get something you want, the escape or avoidance categories of self-injury. One way it's oftentimes very useful to think of self-injury is that self-injury is essentially a form of communication. What is the person attempting to communicate? Developing intervention strategies that provide an individual with a form of communication that produces the same outcome as their self-injury and does so consistently enough and efficiently enough that it eliminates the individual's need to communicate using their self-injurious behavior. So we're going to make a transition here. So we're going from theories to assessment of self-injury. And so the big question is, why is it critical to successfully conduct a comprehensive functional behavioral assessment of self-injurious behavior? And this is, if I had everyone in a room, I would ask that question and ask you all share your theories. I'm going to give you just a few seconds to think about it. But a comprehensive functional behavioral assessment for self-injury is critical because self-injury is influenced by different factors in different people. So in about 60% of individuals, we know self-injury is socially maintained. So they're engaging in self-injury to control the actions of other people, to get something they want, to get out of something they don't want to do. We also know that about 40% of self-injurious behavior is non-socially maintained. So the persons are engaging in it because there's something they find enjoyable or pleasurable about engaging in self-injurious behavior. And the problem is that you cannot tell by topography or form of self-injury by simply looking at a person whether or not their self-injury is socially maintained or non-socially maintained. And then why do you care about that? Well, you care about that because your intervention, the treatment you try, needs to be linked to the reason why the person engages in their self-injurious behavior. And interventions that work for socially maintained self-injurious behavior have virtually no chance of working for individuals whose self-injurious behavior is maintained by non-social factors, and vice versa. So identifying whether or not it's social or non-social is the key. And the only way we have to do that is by using functional behavioral assessment tools. So what are the things we can do? So particularly a good starting point if you're someone like a parent, you're concerned about your child's self-injury, you've tried a bunch of things people have recommended and they haven't worked, is just to collect some really basic information and share with people. How often does self-injury occur? Does it occur in particular places? Is it associated with particular activities? So if you're a parent, collecting some of that data doesn't have to be anything fancy. If you contact me, I would be happy to send you some very basic data collection sheets, but you can do something as simple as straightforward as have a notebook, record tallies in it and where the behavior occurred and under what situations. The slide here, it kind of focuses on the need for functional behavioral assessment. It's mandated by law. It allows us essentially to make that distinction we've talked about just a few moments ago between socially maintained and non-socially maintained self-injury. Again, emphasis on knowing why behavioral function. If you don't know why, the probability, the likelihood of looking at a list of interventions for self-injurious behavior and selecting one that might work goes down dramatically. So to focus a little bit more on common functional behavioral assessment tools. So if you're a parent of someone who engages in self-injury and you're working with a team of people, you might want to ask, have we used these assessment tools? If you're a teacher, you may want to ask the other members of your educational team, again, have you used these assessment tools? And we're just going to kind of go through what they are, advantages, disadvantages, ones that parents and people with a little bit more modest background can use, and ones that may require some advice from someone like myself who have had a lot of professional training working with individuals with self-injurious behaviors. So there's a series of questionnaires that are designed to help you identify behavioral function, and they're listed at the top. So one's called the Motivation Assessment Scale. The other one's called the Question About Behavioral Function. Another one's referred to as the FAST, which refers to, I believe, to the Functional Analysis Screening Tool. And these are simply, I'll show you some example of questions. There are a series of questions that you answer about a particular behavior, self-injury in our case. And there are questions related to both social functions and non-social functions. And the advantages of these questionnaires is they're quick to fill out. They don't require expertise in formal training. The disadvantage is they tend to kind of give you a broad picture. So they suggest that there's multiple factors involved, where if you look in more detail, there's oftentimes a predominant cause of the individual self-injurious behavior. So they tend to suggest multiple things when in fact, most likely it's attention, it's escape, it's automatic reinforcement. So examples of questions, and you rate these questions. You respond on typically on a Likert scale. For the QABF, it's a 5-point scale. It goes from 0 to highly likely to influence behavior. So does the person engage in the behavior to get attention? Does the person engage in the behavior to get something he or she wants? Does the behavior occur when you stop attending to the person? The other thing we can do from an assessment standpoint, so with these functional behavioral assessment tools, what I often tell people is what you're looking for is agreement across tools. You're more likely to get a clear answer if you use multiple tools versus a single tool, because they all have their strengths and their weaknesses. But one of the things we can do is we can observe, what commonly precedes self-injurious behavior, and then what the consequence is, how people typically react. And we can do that multiple times and look for patterns. And with ABC data, oftentimes people ask me, how long should we collect ABC data for? Based on my clinical experience, you need a fair number of occurrences of behavior. But usually, if the person engages in self-injury at a fairly high rate, usually you should, if you haven't attained a clear answer in about 4 to 6 weeks, you're probably not going to get a lot of additional benefit from collecting ABC data for 2 months, 3 months, 6 months, or a year. So this ABC data is meant to be a relatively short-term assessment procedure. Typically, you collect it from 2 or 4 weeks. You look at patterns of what comes immediately before the behavior and what follows it. Another tool that some people use is called a scatter plot. A scatter plot is simply looking at the distribution of the behavior per day over time. And this is an example from Paul Touchet in 1981 published article, really sort of illustrating the potential use of the scatter plot. In this case, they showed that the individual's challenging behaviors were clustered, I believe, around sort of 12:30 to 3:30. What they did is they revised the person's schedule to remove some of the activities and modify the activities to meet the individual's needs to reduce the likelihood that they would, in this case, it's not self-injury, but in this case, they would engage in physical aggression. So scatter plots may be useful for looking at temporal patterns across time. The problem with scatter plots, so the warning I have is if you're going to use a scatter plot, it assumes that a person's schedule is highly predictable. So if you say to yourself, Johnny's schedule isn't very predictable, it changes all the time, there really probably isn't a great rationale for thinking that a scatter plot's going to reveal a pattern, a temporal-based pattern. So if you consider using a scatter plot, the important question is, does the person have a predictable schedule? If they do, a scatter plot might be useful. If they don't, then a scatter plot is likely not to be particularly useful. So all the assessment tools we've talked about to this point are ones that parents, teachers, educational teams can use with either no support or minimum support. And well, there would be resources and web pages on the internet. You could read about them. They would give you a pretty good chance of collecting ABC data in a way it might be potentially useful. For self-injurious behavior, there's an assessment protocol called the functional analysis that's sort of considered by behavior analysts like myself the gold standard for the assessment of self-injurious behavior. And this is an assessment that would require consultation from someone with expertise in the conduction of a functional analysis. And it should be, a functional analysis should never be conducted without support of someone who's received significant training in how to conduct them, who's on site to give people moment-to-moment feedback when the assessment is taking place. And what a functional analysis involves is setting up situations and putting the individuals in situations where you're manipulating antecedents and consequences and seeing whether or not you can produce or occasion the occurrence of challenging behavior. So let me give you a couple of examples of what you do. So in the analog functional analysis in the demand condition, what we would do is we would identify an activity that the person finds, we believe, low preference. We would ask them to do it. So it might be, I may ask Johnny to do math problems with me. I would prompt them, I would instruct them to do the math problems, and then contingent on the occurrence of self-injury, I would remove the work, say, okay, you don't have to do math problems for a period of time, give the individual a break. After, say, a 30-second, 1-minute break, I would go back to asking them to do work again. So if their self-injury is maintained by escape or avoidance behavior, then this condition should produce relatively high levels of self-injurious behavior. In the positive reinforcement condition, what I would do is be with the person. I would say to them, I have some work to do. I wouldn't interact with them unless they engaged in self-injury. And then I would briefly, if they did engage in self-injury, briefly provide them with attention. I would say, oh, don't do that. Please stop. Those sorts of things. So I'm testing a series of conditions. I'm alternating them. And what I'm looking for is in one of these conditions, does the individual consistently engage in self-injurious behavior? So the question is, can I produce their self-injurious behavior? And if I can produce it by manipulating the antecedents and consequences, then I can be confident that I've identified the function of it from the purpose of the individual. And these are graphs. I'm going to show you a couple graphs of analog functional analyses. You would, again, these require expertise to interpret. They are sort of interpreted like I picture it like a doctor kind of reading an x-ray. If you're like myself, you don't possess the skills to interpret your own x-rays. Very similar with an analog functional analysis. It's not impossible to learn how to do, but you would need a little support. So in this case, the individual is most likely to engage in self-injury during the demand condition. So I have identified that this individual self-injury is maintained by social negative reinforcement. They do it because they want to get out of things that they don't want to do, in other words. Another example of an analog functional analysis, and in this case, the person does it for a couple reasons. They do it to gain access to things that they want, tangible items or activities or get out of something that they don't want to do. Again, sort of a summary of functional behavioral assessments. Series of assessment tools, questionnaires, ABC data, scatter plots that lots of people can use, may provide you with an answer to the question of what's the purpose or the function of self-injury. But in some cases, those assessment tools will not be sufficient. And then the typical behavioral clinical recommendation would be that the person may need to participate in an analog functional analysis, set up situations and see whether or not we can actually produce the self-injurious behavior. So we're going to make another transition. We're moving from assessment to intervention, and consistent with our behavioral model and the fact that we know that self-injury has social causes and non-social causes, we're going to look at interventions first for socially maintained self-injury, and then we're going to look at interventions for automatically maintained, non-socially maintained self-injury. We're going to use pica as our example of self-injury that's maintained by sensory consequences, because several people in the survey identified that they were interested in interventions for pica. So function-based interventions are hypothesis-based. You're developing an intervention or treatment based on your belief of why the individual engages in self-injury. And the first category is antecedent-based interventions. Again, we're talking about things that are socially maintained here. What we do in antecedent-based interventions is we attempt to alter the individual's immediate surroundings, their environment, to eliminate those things that may serve as what we refer to behaviorally as the discriminative stimulus, but the cue signal for their self-injury. And what are things that people have done? So in the case of self-injury maintained by escape or avoidance to get out of what the person wants to do, sometimes people have eliminated particular tasks or activities. They have done things like embedded. If you know a particular task is difficult, likely to produce escape-maintained behavior, you ask the person to do it, but only in the context of also asking them to do things that are easier for them, less likely to produce frustration, less likely to produce self-injurious behavior. The thing you need to watch about eliminating tasks or activities is, sometimes what I see clinically is people have correctly identified that self-injury is escape-maintained, but they then treat it by eliminating all instructional demands. Well, what's the problem with that is, you're not very likely to learn anything. You're not very likely to be actively engaged if your day consists of predominantly only being asked to do easy things we know that you'll cooperate with. Sometimes what we do is we change the way we ask or give directives. Sometimes, individuals with autism have difficulty processing verbal statements. So what we might do is give them only short, very clear directives, and we would combine our directives with visual supports. Sometimes we take a difficult activity. So if my self-injury was escape-maintained, and it was escape-maintained related back to our earlier example of brushing our teeth, what I might do is break brushing your teeth down into discrete steps. I would reinforce you for completion of each of the steps, thus making this big task easier by having you complete sub-steps and reinforcing the completion of each of those sub-steps. For socially maintained self-injury, we often use what we refer to as reinforcement-based interventions. These consist of contingent reinforcement and non-contingent reinforcement, and what we refer to as differential reinforcement. And I don't think I actually have a slide on non-contingent reinforcement, but let me give you a quick example. So I engage in self-injurious behavior because it's a great way to recruit, get attention from my family members. What you would do if you use non-contingent attention is you would establish a rule that I'm going to attend to the person who engages in self-injury every X number of minutes. I'm going to say something positive to them. What essentially you're doing is flooding the person with attention. And from the perspective of the person engaged in self-injury, why would they bother to exert the effort to engage in self-injurious behavior to get your attention if they can just kind of sit back and soak up the attention that's freely available? In behavioral language, we refer to that as non-contingent reinforcement. The disadvantage of it, if you're someone like a parent, a teacher, is that typically non-contingent reinforcement, non-contingent attention to eliminate attention-maintained self-injurious behavior requires you to attend to the person a lot. So essentially what you're doing is flooding them with attention. People report to me that's difficult to do. You know, you're at home, you're trying to do all the other activities you're required to do in your life, and they just find it very difficult to provide that very constant high rate of attention. What are alternatives in terms of reinforcement strategies? So you can do what is referred to as a differential reinforcement of other behavior strategy, which is a DRO procedure. You identify a particular interval of time, and if the person doesn't engage in self-injurious behavior during that interval, they are provided with a reward or reinforcement. Typically, you have to start off with relatively brief periods of time. So behavior-free for 5 minutes, 10 minutes, 15 minutes, and then contingent on success, we lengthen or increase the length of the interval. The other thing we commonly do is referred to as a DRA, differential reinforcement or alternative behavior. For self-injurious behavior, we really typically focus on two things: the reinforcement of alternative communication strategies or the reinforcement of engagement in activities in general. So you may ask yourself, why would you reinforce engagement in activities, engagement in a schedule? Research has shown that active engagement in general competes with all challenging behaviors. So it makes sense. You're busy, you're doing things you enjoy, that you're less likely to engage in challenging behavior. So engagement's good. So if you're a parent of a child with autism and engages in self-injurious behavior, one of the basic things you can have in place is, do you have a really comprehensive schedule at home? Have you done everything you can, particularly during those down periods at home, to keep your child busy? And we know keeping children busy is likely to produce less self-injurious behavior in general. A little slide on functional communication training. Functional communication training, again, only applies to socially mediated challenge behavior. I do it to get what I want. I do it to get out of something. I do it as a way to get attention. And, if we take escape maintained self-injurious behavior as our example, functional communication training would consist of teaching the individual to request a break in its most simple form. What I find is when I go out, oftentimes people report to me, David, I've tried functional communication training and it doesn't work. If you've successfully identified what the person gets out of their self-injurious behavior, and you're right, functional communication training should work. What I find is oftentimes it's not, people's statement that we've tried functional communication training and it doesn't work. What it really means is that people need some help fine-tuning the communication skill so the person actually uses it to replace their self-injurious behavior. So for example, we know from studies of functional communication training, response effort is really important. So if the communication response is more effortful for the person to display than self-injurious behavior, they're not likely to use it. So we have to look at the effort. Is the effort actually less than their self-injurious behavior to give the alternative communication response the opportunity to work in the way we want it to? So the really point there is, if you say to yourself, we've tried functional communication training and it doesn't work, you may need a little bit of support from someone like myself that really knows the 5 or 6 ways you can do some fine tuning to increase the likelihood it'll be effective. And this is just an example of a situation in which I've used functional communication training. In this case, it only worked when we combined it with behavioral extinction. So behavioral extinction refers to withholding the reward or reinforcer it's maintaining the behavior. One thing someone might tell you to do for self-injurious behavior is to implement extinction. Another common term for extinction is sometimes we refer to as planned ignoring. Extinction refers to withholding the reinforcer or the reward that's maintaining self-injurious behavior. So if my self-injury is maintained by attention, you would ignore me for a brief period of time every time I engaged in self-injury. And then you would also attend to me when I'm not engaged in self-injury. The problem with planned ignoring for self-injurious behavior is that the characteristics of extinction may be difficult for us if we're a parent, educational team to tolerate. So in general, planned ignoring takes time. One of the other characteristics of planned ignoring is behavior tends to get worse before it gets better. So it makes sense. My SIB has been a great way for me to get attention for several years. I'm going to persist. I'm going to stick with it till I really identify it no longer works. So behavior tends to get worse before it gets better. Takes a long period of time. For some individuals, you cannot tolerate having them engage in self-injury for a prolonged period of time due to the potential tissue damage it produces. So this is an illustration of the extinction curve. Again, planned ignoring takes time. Behavior may get worse before it gets better. Around session 15, you see that little bump in behavior. That's referred to as spontaneous recovery. Behaviors placed on extinction tend to come back on their own, even if they disappear for a period of time. very briefly, there is a literature out there on punishment-based strategies for SIB. And really, we're talking about things that really would require some support. People from someone like myself that knows the subtlety, again, of fine-tuning punishment-based strategies. Some stuff that's rarely used outside of specialized treatment programs are things like facial or visual screens. So covering the person's eyes briefly contingent on the occurrence of behavior, a 30-second basket hold. You cannot use a facial visual screen in an educational setting without special approval by New York State. Those procedures are, and in my opinion, only should be used under very close supervision. If I meet someone with self-injury that I believe needs treatment with those procedures, what I've historically personally done is referred them to a very specialized treatment program so that we really know that they have a very, very comprehensive functional behavioral assessment, analog functional analysis. So, if you're an educational team, someone says to you, oh, I found this study on a basket hold, maybe we should try that. I would really caution you to refer the person to a specialized treatment program if you think that they're in, if they're at a point where they need those procedures to be considered. Try and think of places you could get advice on that. We have a behavioral clinic in our division. Also, Hank Rohn has a program in Syracuse, at Upstate Medical. He has expertise in those procedures. So sort of more of a warning. My advice is not to use those unless you're doing it under direct consultation with someone that's an expert. Other procedures people may use that are punishment-based includes response costs, overcorrection, and timeout. So timeout is the withdrawal of a positive reinforcement or a loss of a positive reinforcement contingent on the occurrence of the behavior. If we're talking self-injurious behavior, you would only want to use timeout for behaviors maintained by attention, not behaviors that are maintained by a desire to get out of things you don't want to do. I would view timeout as not an initial treatment that you would want to try. It would be something you would want to try after other approaches like functional communication training have failed to be successful. Response cost is the loss of a reinforcer contingent on the occurrence of behavior. So if you were doing a differential reinforcement procedure and reinforcing me for the absence of behavior for a particular period of time, response cost would consist of contingent on the occurrence of behavior, doing something like removing a token I've earned from a token board. So there's a little bit of information on punishment-based strategies. Again, a big caution here. So punishment-based procedures have some negative consequences that we all should be aware of. So if you use a punishment-based procedure, you shouldn't expect the person to want to spend time with you. So people tend to avoid individuals who have implemented a punishment-based strategy. Punishment doesn't teach replacement behaviors, and you can make an argument that punishment-based strategies are a poor model of a way to interact with other people. So very quickly, I think we have about 10 minutes remaining. So we focused on interventions for socially maintained self-injurious behavior. And we're going to use pica as our example of things you may try for automatically maintained self-injurious behavior. Self-injurious behavior, again, it's maintained by sensory consequences. So the important point here is options for evidence-based options for self-injury maintained by social consequences they're significantly fewer. So if we made a menu of everything to try for socially maintained self-injury, we could come up with a pretty long list based on what people have done in the research literature. If we made the same list for self-injury maintained by automatic reinforcement or sensory consequences, the list would be much shorter. So I'm going to go over, these are really the empirically documented effective interventions for self-injury maintained by social consequences. So one of them is response blocking. So physically preventing the occurrence of the behavior. If I hit myself in the head, that would consist of another person putting their hands between my hands and my head and preventing me from making contact. So that's response blocking. In our example for pica, and again, pica is eating non-edible objects. Pica is a form of self-injury. If you believe the research-based literature, it's almost always exclusively automatically maintained. And people have shown that if you consistently prevent individuals who engage in pica from picking up items that they're attempting to place in their mouth, and you do it at the point prior to them getting the item in their hand, and you do it consistently means all the time, essentially, you can eliminate pica, you can greatly reduce pica, which is what this treatment graph illustrates. What is the other, really, from my perspective, the predominant major intervention for automatically maintained self-injury? I mentioned this earlier, but really promoting engagement. So if in alternative activities. So if I engage in self-injurious behavior because there's something I find enjoyable or pleasurable about it, what the research literature suggests is that the best way to address that is to essentially keep me busy, which is essentially what this study shows for pica. So you provide alternative activities, toys to play with, access to an alternative edible item, in this case popcorn, that provides access to the same or similar source of reinforcement, then you get reduced rates of pica. And what Lewis Agopian shows in a study is that, so the problem with this is, if you ask me in general, I would say automatically maintain self-injury, increased engagement. But what people like Lewis Agopian have shown is that many people simultaneously engage in self-injury and will engage in functional activities at the same time. So Lewis has developed, along with some other researchers, a procedure called the competing items assessment, where essentially you expose the person to various activities and you measure whether or not they engage in the activity and whether or not when they're engaged in the activity, that are they also engaged in self-injurious behavior. You then enrich their day with those items in which they engage and do not at the same time engage in self-injurious behavior, in this case, pica. This is a protocol, again, you would need probably some support to conduct. And the problem with it is it can take a fair amount of time to identify a comprehensive set of things that person will engage in, that they will not also simultaneously engage in their self-injurious behavior. So a competing items assessment, although it's not difficult to conduct, they tend to be pretty time intensive. And before we take your questions, there's also a literature on medication-based treatments for self-injury, which really isn't the focus today. And when we're talking about self-injury and medication, again, to link it back to assessment, we're really probably predominantly talking about self-injury maintained by medical biological factors, internal automatic sensory reinforcement. Generally, the two medications that have the most support for individuals with autism are both atypical antipsychotics, Risperdal and Abilify, like all powerful sort of chemical agents. They have potential powerful effect that works in both directions. So there's a side effect profile and some fairly good evidence that they can reduce self-injury. And in general, in my field, the field of behavior analysis, the model that we follow is a least restrictive treatment model. So we tend to start off with behavioral treatments. If those don't work, then add medication. And there's some interesting data out there that show that for some individuals with severe self-injury, the combination of a medication and a behavioral intervention is more effective than either in isolation. So if you're me, you're not anti-medication, but you're pro, following a least restrictive treatment model. So I want to thank everyone for attending today. And I think we have a few minutes for questions.
Yeah, thank you so much, David. All right, folks, so we have a couple questions coming through. Let's pull these up. Let's see, first, yes, absolutely, to a copy of the presentation. So everybody will receive an email with that survey link for feedback, as well as the link to the recording of the presentation and the PowerPoint slides. We know that you received a lot of important information in a short amount of time this afternoon, and we want to make sure that you have these slides available, as well as our contact information. So if you have any follow-up questions for David, feel free to contact us. We're just checking out a couple other questions. Thanks for sitting tight.
So the first question is about, I think, if I'm following expedite right in the process, I believe my child's self-injurious behavior is escape maintained. I don't feel like I give in. I think it's sort of, what are the next steps? I think the person then said a follow-up saying that their child's 16 years of age. Sounds like SIB disappeared for a period of time and returned. So one of the characteristics of self-injurious behavior is it tends to wax and wane across time. So there's individuals who have periods of time, sometimes years, with low rates of self-injurious behavior. It comes back. If your belief is it's escape maintained and you feel like you've consistently not given in to your child, it probably points you in the direction of looking at, are there other factors? So are there some of those health conditions that are present today that weren't present for the last several years? Mm-hmm. So, the individual uses their SIB to get out of particular activities, but in the presence of that particular medical condition, they're more likely to attempt to escape. It's really hard to tell without spending time with the person. It sounds like to me that you're at a point where you probably need some more concentrated support from someone with expertise.
Yeah, that's a great question. And David, if you wouldn't mind actually giving us a little bit of information about the USAID's community consultation program. Some of folks, many of you might be familiar with this resource that we have through the U of R of a very talented team of professionals that David is actually the director of. So David, if you wouldn't mind just giving us a little background.
Yeah, so options for help. And there's a variety of them out there, but to kind of do a plug for ourselves here in our division. So we have our community consultation program, which is a fee-for-service program typically supported by a contract between our division and an agency or a school program. We go out, we see individuals in the community and provide direct consultation for a variety of issues, including challenging behaviors. Within our division, there's also a couple clinics. There's a behavioral parent training clinic, and there's a behavioral intervention clinic. Those clinics do take, there's a screening process and a criteria. So to access them, you would have to be screened. They take insurance and also Medicaid services. So that's a couple options. Within Western New York, if you're in other areas of the state, there's other options. You're welcome to contact me, but Hank Roan has a nice program at Upstate Medical. Helen Yu has a program in the New York City area. So if you contact me, I can get you in touch with folks. So there's a question about self-injurious skin picking. Again, if you contact me, I have some resources I can send you. They're talking about an alternative response. Skin picking in individuals with developmental disabilities and autism hasn't been particularly well studied. There's a recent study that reported for one individual a reduction in self-injury. And what they did was they covered open sores with Band-Aids. They faded the size of Band-Aids across time. And they conceptualized that as the Band-Aid being a form of response prevention, response blocking. So there was something that the person found enjoyable, pleasurable about picking their skin. The president of the Band-Aid successfully blocked that. I believe there's also a differential reinforcement. Some data on differential reinforcement. Again, if you contact me, I actually have those resources on my computer. I'll send it to you. There's, for self-injurious skin picking, there's, for people without disabilities, there's a lot of clinical trials of medications. Not surprisingly, I think the outcome is like a lot of medications, Risperdal and Abilify, you see the same thing. They appear to significantly help some people and may not be useful for other people.
Great. All right. Wonderful. I'd like to take the time to thank everybody for joining us again this afternoon. I hope that this information is helpful to your everyday practice. And please, again, feel free to give us some feedback as well as other topics that you might be interested in learning more about. And again, don't hesitate to contact David or those of us at the Regional Center for any other follow-up or questions that you might have. So with that said, I'd like to wish everybody a wonderful evening, and we hope to talk to you again in the future at a future webinar. So thanks so much and have a great night.